Welcome to another episode of the Federal Newswire Lunch Hour Podcast with your host, Andrew Langer.
Hey, everybody. Welcome to another episode of the Federal Newswire's Lunch Hour Podcast. I'm your host, Andrew Langer. So glad I could join you and you can join me today for this in-depth discussion of healthcare policy. If you're watching us on our YouTube channel, you know you can always check us out on one of the many fine podcast platforms at which you can find the Lunch Hour. We're on just about all of them. If you're listening to us on one of those many fine podcast platforms, check out our YouTube channel. Check out, if you're not following it, at Lunch Hour Pod on Twitter. I still call it Twitter. That's how you get up-to-date information about all the podcasts that we have. You're going to see clips of our wonderful guests, including the guest I'm about to interview today. And as always, subscribe, hit the like button, leave a comment, and let your friends and family members' friends all know how much you are how much you are enjoying the Lunch Hour Podcast. Very excited to bring our guest on today. I had the privilege of seeing her recently at the Freedom Fest conference out in Palm Springs, where she did a really wonderful panel talking about some of the issues that are near and dear to my heart. Her name is Twila Brase. I actually am putting my glasses on, Twila, for this. She's the co-founder and president of Citizens Council for Health Freedom, a national patient-centered, privacy-focused, free market 501c3 health freedom policy organization launched in 1998 to protect patient and donor freedom. She's the author of the 8-time award-winning book, Big Brother in the Exam Room, The Dangerous Truth About Electronic Health Records, which is now in its 4th printing. She's done a whole host of great things. And most importantly, she has a master's in public health. She is a registered nurse. And we are just so thankful for having her expertise on here. And let's start with this, Twila, because folks are uninitiated. Let's talk about the Citizens Council for Health Freedom and the work that you do there. Tell us all about that and how you got involved, how you made the transition from nursing to advocacy.
Well, I guess the way I made the transition is because I learned about the Clintons' plan to take over the healthcare system by putting us all in managed care, which is now known as a health plan. But that was their plan to take over the healthcare system in this country. And I was working as a nurse at the time, and I thought if they take over healthcare, they'll take over the country.
Right.
And I wasn't willing. I wasn't willing to let them socialize our healthcare system or take over the country. And so I've been doing this work for 30 years, and this organization has been around for 27. And there was a precursor organization before that. So again, 30 years. And the whole idea here is to protect patient and doctor freedom and to do it in a way where we strike at the Achilles heel of the current healthcare system, which is one of the reasons why we spend a lot of time on privacy.
Right.
Because he who holds the data makes the rules. And so every tyrant knows that. Every tyrant conducts surveillance, and there is surveillance being conducted today big time in our healthcare system. And I write about that in Big Brother in the Exam Room, my book.
It's really interesting. I had this conversation. Who was I talking to about this? I was talking to somebody late last week about this idea. I'll never forget this. I was in studio, radio station in Baltimore. A colleague of mine was on the air, and he was talking about the issue of privatized DNA databases, 23andMe and others. And he said, it's fascinating to me. The same folks who would rail against government, if government insisted that you submitted a swab of your DNA to them to be put in a massive database, you would, rightly, civil libertarians would rail against this as an abuse of government power. Yet if you do the same thing and you say you can pay $100 for the privilege of doing this, then people are about, take my money, take my ID. There are twin sides to this, aren't there, Twila? Talk about that.
Well, it's a matter of who controls it. Is it a private entity or is it the government? Because the government has police power.
Right.
The private entity like 23andMe does not have police power, cannot decide that it can't put you into jail. However, of course, depending on the fine print of the contract that you sign, they could give it to government, but then it would still be very hard for government to then claim a police power over something that they had gotten from a third party. But it's not unheard of at all. And when you mention this issue in particular, We discovered baby DNA. And so the state government storage of newborn DNA after birth, long term, Michigan is storing it 100 years, 100 years to indefinitely, right? And so when you talk about adults would be perturbed, now think about mama bears
Right.
and papa bears who discover that the government has taken their baby's DNA, is storing it, using it, sharing it, selling it, everything.
It is amazing to me, right? Because, listen, this is so fascinating. Don't worry about that. We get down to the issue of, technology and how things change over time, and asking these sort of consistent questions and about the persistence of things that remain in technology, right? So you think about it, the issue of consent, right? If when I turn 18, when any individual in America turns 18, there are specific rights that they have that the government can't abuse, like taking a DNA sample. But this idea that we're going to take the kid's DNA sample and keep it in perpetuity because they're a baby. I mean, how are you pushing back on this? Is there an effort to say, okay, those samples need to be destroyed after 18 years, or are people just not thinking about it? Because I would think that if I turn 18, I should be able to turn around and petition for my DNA sample to be destroyed because it's violative of, my Fourth Amendment rights.
It should never be taken.
Well, I agree with that.
Right?
Absolutely.
So you shouldn't have to opt out of anything. If they want it, they have to come and ask permission. And then
100%.
when they have done, okay, so I'll just start sort of a little bit at the beginning. One, we have answering your question. One, we have a special website, a special page called itsmydna.org.
Right.
Itsmydna.org. And this tells parents you can find out how long your state is retaining the DNA. Now, since we discovered this in 2003, there have been 6 lawsuits, either for parents who discovered it and didn't want it, or the fact that Texas and others were giving, 4 states gave baby DNA to federal government to create a special military database of Black and Hispanic. They were looking particularly for the DNA from Black and Hispanic babies. Then there was the most recent lawsuit has to do with in New Jersey. The police came into this DNA storage. I think New Jersey keeps it for 23 years. And they used it to find a criminal, and they never asked the parents. And so there's a lawsuit there. In Michigan, there's a lawsuit from 2 attorneys who discovered that the state was keeping their DNA. Now, Indiana changed their DNA policy to 23 years of baby DNA will be kept in perpetuity. But going forward, they are asking the parents about the ability to use it for research.
Well, let me ask you this, because this is what gets me about this, and why I have concerns, even with parental consent. Because I can see a situation in which you're at one of the the most joyous moments of a parent's life, right? The birth of a child, you're getting all of this paperwork put in front of you here. You're not thinking about, Fourth Amendment rights or other, Fourth Amendment rights, Fifth Amendment rights, et cetera. You're just thinking about the joy. And somebody comes to you and says, all right, you see this sheet that says a DNA sample will be taken and retained. And you ask about this. I can see a situation in which a doctor or nurse or somebody unscrupulous in government says, oh, well, we're just doing this to protect your child, right? In case your child is abducted or something happens, we think we ought to have this database that's out there. And if you're a parent, you're not thinking, well, how long they'll take if they need this, why do they keep it for 23 years? It just seems to me, and you're right, it shouldn't be done at all. I know that's a lot there, Twila. How many states have this? And talk about this issue.
So this
happens. Where we're going to go, but this is fascinating. Thank you.
This happens because of newborn screening.
Yes.
And newborn screening is considered the largest population-wide genetic testing program in the country. But people don't understand that newborn screening is genetic testing. And it happens within the first 24 to 48 hours of birth. And sometimes they'll take the baby, sometimes they'll do it in the room, and they prick the heel, they squeeze blood out of the heel onto special filter paper, and then they take it away. And the parents don't understand that this is where the long arm of the government has reached in, because it gets sent to the state. It does not go to the hospital laboratories. And then states back in the 1990s decided that this was a national treasure.
Right. Sure. Of course it is.
4 million babies are
That's
born.
data.
4 million. 4
Yeah.
million babies are born every year. And so they've called it a national treasure, but they never asked. They just took, stored, used. And so this is a total violation. This is a newborn citizen with all the rights of a citizen. Just because they can't vote doesn't mean that they don't have any constitutional rights.
Absolutely, yes.
And so the parents aren't consenting at all to this. They're not even consenting to newborn screening.
Right.
Because it's not even a doctor's order.
Right.
It's something that the hospital just does.
It's an administrative thing. Yeah. Again, it's like.
Because it's a law. Because it's a law.
So, and every state is doing this and has been doing this?
Every state is doing this, but since our work in 2003 unveiling this secret storage, there are far fewer states keeping it forever or, for 10 years or forever. So I think there's probably about 16 states now, but there were a
I can see, Radley Balco writing about this. I mean, this is why I wanted to talk to you. Why I was working on this so much. Let's shift gears though a little bit, because you and I had a brief conversation at Freedom Fest about this. I appreciated. I asked the question about this. We fundamentally get something wrong. Actually, you framed it well, because you talked about the issue of HMOs and managed care, and I'm with you, right? I think that the big government, single payer system is a non-starter. The HMO system is a non-starter. We fundamentally don't understand and don't deal with healthcare as a resource economics issue. I asked you about this. I want to hear I want my listeners to hear your thoughts about this, about what we've been getting wrong for so long about health care as opposed to health insurance in America.
Yeah, so the history is interesting because it was Ted Kennedy who put in the HMO Act of 1973 and the $375 million to create these experimental entities around the country, and then forced all employers with 25 employees or more to offer an HMO. And this built up the HMO system. Of course, he is a single payer system. He was a single payer system guy, right? And Hillary wanted to do it for all, HMOs for all. And Obama did it for health plans, qualified health plans for all. So I think what people don't understand is that they think they have insurance when they have a prepaid plan, just like socialized medicine. You pay all this money in taxes and then you've got this thing at the end. Although we're not quite there, but it is the corporate version of socialism, socialized medicine, because they control the data, the doctors, the dollars, and the decisions. This is socialized medicine, and everybody thinks that they have insurance and they don't.
Yeah, right. I was saying back in 2007, 2008, 2009, I could give everybody Andrew Langer's health insurance and say you're fully covered, but the piece of paper wouldn't be worth the ink that was printed on it, because I can't give you the care that I'm promising to you. It's like this, right? It's like Costco, and I know Costco is a for-profit business, but we all, you get a Costco membership, you're getting a cost-sharing benefit with everybody else, right? The economies of scale that are out there. But when Costco starts to run out of toilet paper or paper towels or Diet Coke, right? They go and they buy more of it, and but we don't. We are losing doctors. We are losing nurses. We have an ever widening gap between the number, especially in primary care, between the number of patients that we have and the number of physicians we have to serve those patients. Talk about that.
Well, I mean, I'm a nurse, right? And people have told me, well, it's good that you got out when you did. And I got out before the electronic health record mandate. And that mandate, the Obama administration considered that mandate, which was signed into law 4 weeks after his first inauguration.
Wow.
They considered that mandate to be foundational to their Affordable Care Act. So they needed to socialize the health data before they started socializing the actual care.
Explain that mechanism, why the data is so vital, why having an electronic health record system is so vital to socialized medicine.
Because it provides all the data. And so a lot of people probably think, well, this is just a unique little system sitting here in the doctor's office. And they don't realize that the law that created the certified government EHR, electronic health
Yep.
record. So doctors and hospitals can't have any EHR. They used to have ones that they liked.
Yes.
Now they have to have the government certified one.
Oh, yes.
And it has to be used meaningfully. So it's called the meaningful use regulations.
Okay.
And so if they don't use it meaningfully, they do not get fully paid, which means, of course, that they have to report all this data on you, the patient. So they're profiling you, and they have to report all this data on every one of their treatment decisions.
Right.
So everything is tracked. Everything is, controlled. Everything is monitored. Everything is measured. And then this, like during COVID, we saw it, right? They have to follow protocols. They're not working for the patient anymore. They're working for the big systems. They're working for the health plans. They're working for the government.
It is a form of the Chinese style surveillance social crediting monitoring system, right? I mean, that's essentially, but a focus on health. I mean, is that an apt analogy?
Well, sort of. I guess I've never thought about it that way, but it is the way that every doctor is controlled because they know every click of that electronic health record is tracked.
Right.
The other thing is it takes up and consumes so much of their time so that they don't have as much time to spend with patients, but they're sending all this data to the government that the government uses to make claims about bad doctors or too much care or medically unnecessary care. That's the other thing. That's how it gets rationed. Right. They can just tell the doctor it's medically unnecessary. We won't pay for it.
Right. I mean, there's this situation going on right now with this surgeon who has been, documenting her arguments with one of the major health services. I don't want to talk about specifics here. I'm trying to get her as a guest on the show. And she's literally mid-surgery or about to start surgery, and she gets the denial call from the company. I guess the part of the reason why I make the analogy, Twila, is because they can make decisions based upon your choices, your lifestyle choices. So I will never forget debating a woman. Are you familiar with Mimi Roth? A woman named Mimi Roth. So Mimi Roth, Nick Gillespie and I both debated her at various times on TV. She was big on the idea of a fat stamp. If you were determined to be obese, you would get a stamp in your electronic health record that would go with you. And she was unhealthily skinny. I've lost a lot of weight in the last year. Folks who watch the show know that in the last year I've lost a substantial amount of weight. But and this was by choice and for all kinds of reasons. It was a good thing. My point in all of this is, her goal ultimately and her justification was she didn't want to have to pay for other people's bad choices. And I get that, right? But unfortunately, that's sort of where we are right now. And I agree with her. Nobody should pay for other people's bad choices. But on the other hand, what I don't want is for some bureaucrat to start denying the choices that people make because some doctor has determined that they're overweight and they have this stamp going through them. I mean, this is where I'm going with the social crediting system. You get a stamp in your electronic health record that says X, and all of a sudden they will deny you the care that you need because of somebody else's political determination.
Well, of course, that happened during COVID, right? There were actual stamps about being vaccinated or unvaccinated, and care was given accordingly or not. And you were treated very differently if you were unvaxxed or they didn't know your vax status, and then they assumed that you were unvaxxed.
Right.
And it's not even a vaccine, right? Unshotted is what we should say.
Right, sure. Unshotted. I like that.
Right. And but that's absolutely true. But I think the thing for people to realize is how much they do not have health insurance. So health insurance is a contract between you and the insurer. There is no third party in the middle. There's no prior authorization. There's no determinations from outside. There's no evaluating the doctor. The contract says if your doctor orders XYZ for you, we will pay. But of course, it's only for insurable and catastrophic events. It's not for all the little stuff.
Of course,
and so it's very inexpensive, and you have a very high deductible, and you put that policy in a drawer and you shut the door and you go and you pay cash for everything else that is cash based. I mean, I paid cash for a fractured wrist that got seen in the emergency room. It was $1,800. I did try to negotiate it, but they wouldn't because, of course, they were the only provider anywhere. It was way up north.
Right.
So, But you can often negotiate things when you pay cash and pay a lot less. And if you pay at the moment of service, sometimes you can get huge discounts just because you
Sure.
pay right then and there.
Right. I mean, for all kinds of reasons that it becomes more competitive. And, it's so funny. These were not my issues for a very long time. Now, running this coalition against socialized medicine. But, for the last 15 years, even with my wife being a primary care physician, but I spent a couple of months helping promote the HSA issue. And it still remains, and obviously because it remains the most logical thing, that's why we will, we don't do it in this country. But the idea of taking that money that you would normally be putting in a insurance, right? Imagine being able to take, I have a buddy who's paying $30,000 a year for one of these Obamacare plans. And, imagine if he could take that money and put it into some kind of an HSA, which is high deductible, take the money out of the HSA to pay for the deductible when he hits it. I mean, it could be extraordinary. And at the same time, right, the only thing we know is the only time you get advances in medical care, in the technology, is when there is actual competition, right? And I always point to laser eye surgery. Laser eye surgery essentially now costs nothing, next to nothing, because it was not covered for the longest time by insurance. So you would have to pay outright, or you could use your HSA for it, whatever version of it. And the technology just got better and better and better, and the cost went down and down. This is what we're talking about, isn't it?
Yes. And, the fact of the matter is you talked about that $30,000, right? So this is what I call the Obamacare scam.
Right.
If you had to pay that much money, you wouldn't have to pay that much money. If you had a real insurance policy, you would pay very little. I talked to a guy recently who before Obamacare was paying $66 a month for a $1,500 deductible. Now, if he had a really high, I think that was through his employer, but nonetheless, if you have a really high deductible, that's actually what you could be paying. And so Obamacare said, we're going to cover everybody. So now they're offering us high deductible policies for the cost of we pay absolutely everything to the first dollar and dime, right? And so this is such a scam because we all have catastrophic coverage at a first dollar price.
Yes.
And this is because he wanted to get all of the people, he wanted to take away insurance. So, anybody who has a pre-existing condition, they can get coverage. Yeah. That means it's not insurance. We don't have insurance because if your house is burning and you go to get, home insurance to pay for it, they'll say, are you crazy?
Right,
nope.
Absolutely. Of course.
Right. That's real insurance.
Yes,
Insurance
absolutely.
is for the thing you hope doesn't happen to you, never happens. Yes. This is why we want access to lifelong insurance, because even Medicare, 8 years until it's insolvent and will only be able to pay 89% of his bills.
So let's turn around and let's talk about this. It's so funny because also at Freedom Fest, I had a wonderful conversation with a doctor who's very interested in the what she calls the dialysis industrial complex and how, that coverage and how expensive it is. And because the government essentially guarantees coverage for folks who are on major dialysis programs, there have been no technological advances in essentially dealing with chronic kidney disease in years. But why bother? Because we've got this whole complex out there. But we talk about. Well, anyway, let's talk about that, and let's talk about the One Big Beautiful Bill Act and whether or not that helps, hurts. Your thoughts here.
Well, I want to say something about that dialysis issue. Because United Healthcare, the biggest, health plan in the world.
You mentioned them, not me. Just want to be really clear about that. Go ahead.
Well, they're very public, but they bought DaVita.
Yes.
So they really bought the dialysis corporation in the country. And so with the government guaranteeing, then DaVita can just increase their prices, right? This could just be a huge profit center for United Healthcare. And they probably wouldn't want to have any extra technology, which brings me to this thought that people don't understand. So the health plans actually aren't looking for prices to go lower.
No.
Because it's something the Affordable Care Act did, which is called the minimum loss ratio. So they can take for profit, a large company can take for profit 15% of what they bring in. And so, anyway, 15% of a $10 cost versus 15% of $1,000 cost.
Right.
Means that they get, much more money for their profit. They're allowed much more money for their profit if it's $1,000 expense rather than a $10 expense. And that means they can build bigger buildings, have better golden parachutes, the whole kit and caboodle. So they're not looking to lower the cost, because that's just going to decrease their profit, according to the Affordable Care Act, under that ratio.
Are you following this issue of nonprofit hospitals and whether or not nonprofit hospitals are abusing their status? Is that in your wheelhouse at all? Never ask somebody you don't know the answer to, but I thought I'd while you're here.
So I do something called the Health Freedom Minute every day, Monday through Friday. And sometimes I just pick up on these little issues and tell people something. So I know I'm not following it really big time, but here's what I know from the research that I did just to do those little minutes, is that for the most part, the nonprofit hospitals go after patients who don't fully pay their bill more than the for-profit hospitals do.
Wow.
That's what I discovered. And
that's amazing.
Yeah. And so, the nonprofits, they're supposed to have a mission of care and caring, right? And charitability. But it seems that they are less caring and less charitable than the for-profits. And that's from articles that I've read. I haven't done any study,
No. And we know that the plural of anecdotes is not data, but nevertheless, yeah. I mean, there's a whole effort right here the big debate over that issue and what's going on with them. Let's touch on this. The One Big Beautiful Bill Act. I mean, I was astounded that in the so-called Inflation Reduction Act that they raided Medicare to the tune of $250 billion in order to pay for the Green New Deal. It seemed like bad on both ends. But obviously, lots of fixing needs to happen well beyond that in the government-run healthcare sectors. What's the good, the bad, or the ugly with the One Big Beautiful Bill Act?
Well, I think there is some good having to do with the expansion of health savings accounts so that people in the Obamacare catastrophic and bronze divisions can have an HSA, and they couldn't have one before. And then they really protected the direct primary care, the DPC clinics, and allowed people to use their HSAs for DPCs. And for those who have DPCs, they allowed it for $150 a month for singles and $300 a month for couples from their HSA to go to the DPCs. And perhaps the most important thing about that is just that they solidified the DPCs in law in a way that they've not been solidified before. And so they really acknowledged them and they said they're not insurance, they're medical care. And there's a lot of states that have been trying to claim that the DPC clinics, which you pay per month or per quarter or per year, that this is insurance. And of course, it's not insurance. Right. It's a doctor giving you care. But that's what the states are trying to do to sort of shut them down. So that's a really good thing in there. And then, of course, they took a whole bunch of people out of Medicaid by saying, not for illegals, which it should never have been for illegals. Right. And a lot of people don't understand that Medicaid is basically half funded by federal taxpayers and half funded by state.
Yeah, depending on the state, the formulas here and there. Yeah.
Yeah, right. And so, and then they made a whole lot more paperwork for the people who are on Medicaid so that they can't be automatically re-enrolled. Yeah. They actually have to prove that they are still eligible. And there's just so many people on Medicaid that are not eligible.
Right.
And the states just keep re-enrolling them because it means more money for them.
Yeah. Let me ask you this. I mean, because I think we touched on this at your presentation at Freedom Fest. Just getting back to the supply of doctors and nurses and physicians assistants. First of all, where do you come down on calling PAs associate physicians? And how do we change the balance here? How do we get more doctors? How do we get more nurses? How do we get more PAs?
Sometimes I'm very, very glad that I am a registered nurse
Yeah.
who worked in the emergency room, then the school system, but really, the emergency room, my favorite place to work in the hospital. But I do not believe physician assistants should be physician associates.
Yeah.
Already, too many people think that they are physicians, and they are not physicians. They are so far, far, far away from being physicians.
Right.
They do not have the training. They do not have the clinical skills of physicians. They have something, and often they have more, technical skills that, particularly if their doctor that they're under, trains them in certain technical skills. They can be very good in technical skills, but that's not the artistry or science of medicine is the technical skills. Anybody can be a technician, right?
Right.
What you really need to know is how to get to the diagnosis and how to read all the chemistry and how to put all the picture together to know what is happening. And you have to have the experience behind you that says, no, it's not X because I've seen X. It can't be X. And I have stories. I have a story from a physician who they had a PA in their office who kept treating this woman for mastitis, infection of the breast, right? And after the second or third time, months later, he finally decided she needed to see a physician. Well, her cancer had just upstage, right? During that time.
Yeah.
Right. And so there are stories like this because, of course, they don't know what they don't know.
Yeah,
and
my wife has stories like that as well. It's just tragic. Yeah.
And people think, there's a lot of people. I mean, the government and the health plans and even the hospital systems are trying to say this is just, like everybody is equal and equitable. But speaking as a nurse,
no,
I mean, even the doctors, I know it from doctors being in the ER, and I know it from nurses being in the ER. There are more skilled, there are less skilled, there are more knowledgeable, there are less knowledgeable. And then if you don't even have all the training behind you, you cannot be a physician. And so, I mean, I had a clinic once tell me, well, physician X isn't here, but do you want physician Y? And I said, so the clinic added a physician? And she said, well, it's a physician assistant. I'm like, well, okay, well, that is not a physician.
Oh, good Lord.
And, physician assistants are great for what they're skilled to do.
Of course.
But the idea that this is going to confuse patients that make it even closer if they're a physician associate.
I have nothing.
That makes them sound like a physician, not
nothing but respect for nurses. I nothing but respect for nurses. But when nurses get a PhD and they become, doctors of nursing, that confuses the hell out of me. And again, so let me ask you this, because unfortunately, we are in a situation in which most residencies or the primary funding for residency comes out of government. It comes out of Medicare funding. Do you think there's a way around this? Because we can increase the number of medical school billets in America today, right? We could build more medical schools, offer up more slots in the existing medical schools, but we don't have enough residency programs to go around. How do we change that? How do we change the graduate medical education component in all this?
I totally believe that you could, for one, I don't think you have to have 4 years of, bachelor's degree. I don't think you need that. I think you only get your sciences and go on to medical school. But then I think that we could move into internships, real honest to God internships.
Right.
Where people worked with people. And I just heard a physician talking about, a surgeon. Well, yes, a physician, but a surgeon
sure.
who did breast reconstruction.
Yeah,
reconstruction, right? And so he had to take something from the stomach to put it up onto the breast. And a young surgeon, fully qualified, totally out of school surgeon, came into the room and asked if he could, sew up the abdomen while he was doing the breasts in less time. He said, that's a great idea.
Yeah.
Go right ahead. But then he started to watch the surgeon.
Oh, boy.
And he said, I have to figure out a way to get this surgeon out of this room.
Yeah.
So he figured out a way to get him out. And then he undid the stitching because he wasn't even putting
Yeah. Oh, God.
all together, right? And what he said is that because of government regulations, which limit the amount of time that a resident and a doctor can be actually on, 8 hours.
Oh, I get it.
They used to be all through the night, right?
Yeah.
that they do not get as much training as older physicians did. And I think he's the one who said that most of the doctors he knows make sure that they have a physician that is 40 years or older. Right. But another source said 50 years or older.
And once you hit age 55, the numbers are accelerating, the numbers of physicians leaving the practice of medicine. You know, it's interesting because I know at the Uniformed Services University, which is the military's medical school, they're getting their medical students in clinic with physicians within the first 2 weeks of classes starting their first year, which I think is extraordinary. So anyway, then yes, I'm very biased towards uses. Twila, listen, before I let you go, we always talk about this. I always ask my guests this. When you're not doing this kind of work, what are you doing? How do you spend your free time? What are some of your outside interests, if you have any?
Water. So canoeing, sailing, and then there's the beauty of the garden. So I do a lot of gardening.
What are you growing this summer? Or are you flowers?
Beautiful flowers.
Oh, there you go.
Yeah,
I was always big into my tomatoes. Twila, listen, how do folks find out more about the good work you're doing and the work you guys are doing at CCHF?
They can go to cchfreedom.org. And if they're interested in the Real ID issue, they can go to refuserealid.org, our special page on that, which is really hot right now.
Well, listen, I want to thank our guest. She is Twila Brase. She is the founder of Citizens Council for Health Freedom. She just gave you the website, so go and check that out. This brings us to the close of yet another Federal Newswire Lunch Hour podcast. Please, if you are watching us on our YouTube channel, go and check out our podcast, our audio podcast on one of the many fine podcast platforms that are out there. You can take us with you. If you're listening to us, go and check out our YouTube channel and follow us. Follow us on X. At Lunch Hour Pod is where you go. I'm Andrew Langer, your host. Please enjoy the rest of your lunch.
This has been the Federal Newswire Lunch Hour Podcast, hosted by Andrew Langer. Check out the Federal Newswire's family of websites, as well as their social media stream.